Hello, everybody. It's Dr. Lisa. I'm Dr. Lisa Fitzpatrick, the founder of Grapevine Health. I'm an infectious disease doc and CDC trained medical epidemiologist. I worked at CDC for about 10 years, and that was quite an experience. And I'm so happy to be here with you for my first show with Straight Talk with Dr. Lisa. And the reason we're calling this Straight Talk is because I know healthcare is confusing. There's a lot of conflicting information, and sometimes you don't really know what's true and what's not. And so on this show, I and my guests will do our best to give it to you straight. And sometimes it'll be things you already know, things you suspect, and then sometimes it'll be things you probably don't want to hear. Sometimes we all need a little bit of a nudge. I know I do. So we have a great lineup for the next few weeks for you, different physicians and healthcare providers. We have a dentist coming on. We have an emergency room doctor. We have a man I call the Black Quincy. So that's Dr. Roger Mitchell. He's a pathologist, so he will talk to us about what it's like to be a medical examiner. So many great things in store. But I want to first tell you a little bit about Grapevine Health and why I started Grapevine Health. So this show is just another part of Grapevine Health. What we're trying to do with Grapevine Health is to provide trusted, credible health information. So this theme of helping people understand what's true and what's not, I think there's a big need for that, especially right now in this pandemic. There's so much information flying at us left and right, and it's hard to know what to believe. I've spent quite a few hours out on the street, so some of you may know me as Dr. Lisa on the street. If you haven't seen those videos, you can find them on YouTube, and if you go to our YouTube channel, please hit the subscribe button. I'm trying to get to 1,000 followers so that I can go live on the street, so that you can see what's happening in real time. But Grapevine Health is a labor of love. We focus on health literacy. And this show is actually all about health literacy, helping people understand health information and how to use it so that you can be healthy. And my interest in health literacy started many years ago when I was working at CDC. I was on a community panel. It was an Ask the Doctor session. And when the panel was finished, a gentleman walked up to me and said, "How does someone like me access someone like you on a regular basis?" And what he meant was, even though he had a doctor who was taking medications for his health conditions, he just wasn't sure about all the information he was being given. And so he liked the way I was breaking the information down. I'm a big fan of talking in plain speak, because I know medical terms and medical jargon. It's great if I'm talking to my colleagues, but it's not so great if I'm talking to the public. And I also need you to hold me accountable and all of my guests accountable for speaking in plain language. So we want to hear from you in the chat. So leave your comments, your questions. Some of you, we will highlight your questions and your photographs so we can see who's talking. But if you hear us using a phrase or a word you don't understand, please put it in the chat so that we can stop immediately and check ourselves to let you know what we're talking about. Before I introduce the guest today on our first show, I'm really excited for our first guest. I just want to tell you what's different about Straight Talk with Dr. Lisa. In addition to giving it to you straight, no chaser, what's different is we want to invite the community to be in the show. So many programs on the internet involve people like me talking at you. We are lecturing, or we're talking to each other and you're watching. I want you to be in the show, and I want you to ask your questions directly or be in the conversation. And that way, we don't have to worry about something getting lost in translation. You can speak for yourself And if we don't answer your question as you need it answered, you can follow up. So we'll be watching the chat for that. But if you are really interested in being on a show, let us know that in the chat too. And throughout the evening, you can also let us know about different topics you'd like to hear about. We'll try to cover topics that are somewhat controversial or things that are confusing, such as, how do I know which diet is the best diet? I'm even confused by that. First is vegan diets, and then it's carnivore diets, and then the Whole30 diet, and then the keto diet, and on and on and on. So we won't have answers to all the questions, but I think starting with conversation is key. So that's enough blathering on for me. I am so excited to introduce the guest today. And there are two guests, one from the community and one of my colleagues. We're talking about cancer today. Why are we talking about cancer on our first show? I've learned over my more than 20 years in practice that the thing that scares people the most in healthcare, reasons people avoid the doctor, is because they don't want to get bad news. They're afraid to hear they have cancer. And the truth is most cancer is preventable. So we're going to talk about that. So Dr. Sarah Horton is my first guest. And Dr. Sarah Horton is a cancer doctor, an oncologist. Yes. And we work together at Howard University. How are you, Dr. Sarah?
I am fine, Dr. Lisa. I'm so excited. Congratulations.
Yeah, no. So this is not going to be the last time you come on this show, because there's a wealth of topics related to cancer. So yes. So before we jump into our conversation, I also want to invite into the show our community member, Mr. Dwayne Boyd. And I invited Dwayne Boyd to be in the show, number one, because he's just so fun. But second of all, because Dwayne is a cancer survivor and he talks very openly about cancer. And I think that's what we need to do in the Black community, especially. We need to talk about our issues, look for support within community, support each other. And we start that support by talking to each other. So why don't I just let you two talk for a minute? So why don't we start with you, Mr. Boyd? Do you want to introduce yourself?
I'm Dwayne Boyd. I am 56 years old.
I can't hear you.
Oh, can you hear me now? Is this better?
Yes.
Okay. My name is Dwayne Boyd. I'm 56 years old. I'm African-American male, native Washingtonian. As you stated before, I'm a cancer survivor. I had non-Hodgkin's lymphoma, which is not, I'm in what they call partial remission. My cancer has been determined CASE, cancer as chronic illness, because without further measures, which I guess we'll talk about later, I can't be cancer-free. These are some measures that I am at this point not willing to take. So, and I think that's the reason we can talk about some of the beliefs with cancer that certain communities hold. I know it's prevalent among the African American community. I know it's prevalent in my family, and I can tell you that whole story.
Yes, and we're going to dig into that. That's the grapevine talking, right? The family members telling you how to treat your cancer and so on. Yeah.
Thank you. I'm very honored that I'm on your first show, so thank you for that.
Well, I'm honored you're here.
I'm glad to be here. Thank you for
Dr. Sarah.
Yes.
You want to tell folks a few things about yourself?
Okay. So like Dr. Lisa said, we met working at Howard. I was on the oncology team, and Dr. Lisa was infectious disease, and we have been friends for a long time, and we both have a love of what is called health literacy, and which is just talking to people. And Lisa said, we talk to family members, we talk to friends, anyone who has a diagnosis of something that we can help out with. So this is great that you have this show. And like Dwayne, thank you for having us as your first.
Yeah. So I want to just jump right into a myth, because I know there are a lot of cancer myths out there. You know, I have a family member who was diagnosed with late stage cancer, and throughout it was a trying time for all of us, but we all learned a lot together. And one of the things he said to me once was, I didn't know there were a lot of different kinds of cancer. And I said, well, what do you mean? He said, I thought, well, there was just one kind, the killer. So
No.
we are here to help people understand this very complex subject. So the myth I want to start with, we have a lot to cover. We're going to talk about treatment with Dr. Sarah, how you prevent cancer. But first, I just want to put it on the table, the myth about cancer in the Black community. And Dwayne, I'm going to turn this over to you because you've told me this myth that really affected how your cancer treatment journey unfolded. So what was it your family told you that you want people to know?
Well, as I stated, cancer was very prevalent in my family. My mother had 3 bouts of breast cancer. All of her siblings died of cancer. My grandmother, she was one of 13. She and all of her siblings died of cancer. And I just remembered hearing over and over again, not only from them, but from my mother. This was ingrained, this was drilled into me, that you never let them cut you. She always said, if they cut you, the cancer spreads. Once they open up to air, it spreads and you die. And she also told me, because she had breast cancer and it was in some of her lymph nodes, never let them break the lymphatic chain. So I had non-Hodgkin's lymphoma, so not only had cancer, but I had the cancer of the lymph system. So there was the double whammy. A lot of people with non-Hodgkin's have hundreds of cancerous nodes. I only had 6. My doctor would tell me all the time, you're going through all this chemo, you're doing damage to your body. You could be cancer-free if we just remove those 6 nodes. And I would never let him do that. I went through 66 rounds of chemo instead of letting him just remove those nodes by surgery. So that was the myth I always heard, is once they cut you, it spreads and you die.
So Dr. Sarah, sorry, go ahead, Dwayne.
That according to my doctor, that hindered my treatment. I could be cancer-free now if I let them do surgery, which I just refuse to let them do.
You wouldn't let them do the biopsy, yeah. And so, Dr. Sarah, can you just explain why we have this myth that if cancer catches air, that's what people have told me, you don't want cancer to catch air because then it'll spread all over your body. Why do we have this myth, and is it true or not?
So it's tough. It's tough to know where it all started. But if you think back, and I've heard that too in my family, what was said is that, people have experienced things like Dwayne sort of discussed, where they've heard about someone and the person may have had cancer and they went to surgery, and maybe when they went to surgery, when they were opened up, they found the cancer had already spread. And I think people have always heard that. And then they closed them up and they just said it was, there's nothing they can do. Well, that's kind of the seed. I hear that a lot from patients. And somewhere along the line, people can get the idea that, once you're opened up in surgery, air gets into the cancer cells and they get strong and they grow and they spread and there's nothing you can do. And so, below all myths, sometimes there's always little grains of truth where they start from, right? And so you have to go back and think about what are the things that people are concerned about. So one thing that I always talk about is every cancer is different. It's different in the way that it spreads. It's different in the type of treatments that are helpful for it. Sometimes surgery is helpful to remove the cancer and can help prevent you from having the cancer come back. In the majority of what we call solid, like cancers of different parts of your body, lung cancer, colon cancer, breast cancer, surgery is a very important part most of the time of trying to, if you are diagnosed at a stage where you could potentially be cured, like Dwayne's doctors are saying, we could cure you, surgery tends to be a part of that. Chemotherapy is usually the type of therapy you use to try to either, once surgery's been used, you use chemotherapy to prevent it from coming back in some cases, or if it's already spread to the point where surgery really wouldn't help it, chemotherapy is used to help shrink down and keep everything under control, which sounds like what has been happening with Dwayne.
Yes.
Different cancers can be controlled differently by different chemotherapies. It sounds like Dwayne has a type of cancer, and we find that in the lymphomas, the lymphatic type of cancers, that because
And those are in the lymph nodes, right?
right, lymph nodes under your arms, those lymph nodes in your neck, and you have a chain of lymph nodes throughout the entire body. And that's one of the ways cancer can spread. If it gets into a lymph node, it can travel through what's called the lymphatic system to another part of your body. And that's when people say, oh, it spread to the lung. I had cancer that started in the colon, and now my doctor says I have lung cancer. Well, it's not lung cancer that started in the lung. It's just the colon cells were able to spread, sometimes through the lymphatics, sometimes through the blood system to the lung. When you have the type of cancer Dwayne has, the type of, we call it a blood cancer of the lymphatics, because there's so many lymph nodes, there is always a higher chance that you're going to have several areas of cancer. And that's where chemotherapy can be really helpful. If you have a type of cancer like, again, lung or breast cancer, where the cancer of the lung is in one spot, then chemotherapy helps to shrink it, but it usually won't cure it if you just give it by itself. So you have to know what type of cancer you're starting with to know what kind of treatments are going to be effective and work for you at keeping the cancer from growing.
Yeah. I've heard people tell me, well, I don't want to get chemo because that'll kill you faster. You'll be sick all the time. And I just, I'd rather just let nature take its course. So Dwayne, you went through chemotherapy. Do you want to tell people what that was like?
Well, I don't know how this is negating your argument, because I remember a doctor saying to me, the way chemo works is the chemo kills you and it kills the cancer. We just hope it kills the cancer before it kills you.
Wait. You said the doctor told you the chemo kills you?
Yeah. He said the chemo kills you and the cancer. A doctor, maybe one of the doctors associated with many various doctors I went to, said to me, well, the way chemo works is chemo kills you and it kills the cancer. We hope it just kills the cancer before it kills you.
Do you agree with that, Dr. Sarah?
I don't agree with that.
Okay, all right. Continue, Dwayne. I just wanted to check.
It was a rough experience for me. Okay, chemo, everybody's reaction is different. You're not going to have the same reaction universally. There are some common side effects that affect most people, but not everybody's reaction is the same. And the different chemos also affect you differently. I had 3 different types, and I did IV, intravenous, and proton therapy because I ended up with a cancerous lesion on my brain. So I did not have brain cancer, and I liked how Dr. Sarah said it spreads to different areas, but it's the same cancer. So I did not have brain cancer, but I did have a cancerous lesion, and it wasn't a tumor. The doctor always was specific about that. It's not a tumor, it's a lesion. So I had to have proton therapy. So I had 3 different types of chemo, and at times of those types of chemos, of the 3 different types, they would change dose, if I'm making sense. Like the IV, they would change the different types of IV therapy until they found the one that worked. So it's kind of a hunt and guess process. I mean, they try different things until they get the right combination that works for you. I did have side effects. It's not fun.
What
overall.
kind of side effects did you have?
Nausea, vomiting, weight loss, mostly fatigue. Fatigue was the biggest issue. I was tired all the time. I did not have, actually my appetite increased. I did not have a loss of appetite. I had two reactions that my doctor said don't usually happen at all. You've never seen before. My appetite and my sex drive increased. And he said usually it's the opposite. But the fatigue was the biggest issue. I was tired all the time. I had some respiratory issue because I had lymph nodes. I had cancerous lymph nodes in my chin and my neck area. I had radiation on my face that left me with a lot of scarring. So a lot of skin issues that I still have to this day came from the chemo. The biggest issue was the fatigue. I was tired all the time.
Would you do it again if you had to choose? Because people, in response to the people who say, "Oh, I don't want cancer. I don't want chemotherapy. It'll kill you, or it makes you so sick. I just don't want to be bothered." Would you do it again?
Yeah.
Probably not. No.
Why not?
Because I think the surgery would have been the simplest solution.
I was going to ask, would you have done the surgery now?
I think so. I think I would have. I mean, it was 6 nodes. I mean, it's still kind of a toss-up. I had one that was on the base of my spine that was troubling, and I definitely wasn't going to let them cut into my head. That wasn't going to happen. I don't even know if that was needed because he said it was a lesion. I don't know if you can cut a lesion out or remove it, but I just know they weren't cutting on the brain, because once you mess with that, that's the engine of the car. Once you mess with that, everything else goes. But some of the other nodes, I might have thought about it. I would give it more serious consideration now than I would have then. So I can't give you a definitive answer right now. I'd say maybe I'm 60-40. I think I would be more interested now in weighing the options than I would have been then. There was one point I had a node that was pressing on my spine so hard that I was having trouble walking, because the signal was traveling from my brain to my legs to walk. And went in, and then the doctor said, "Okay, we have to cut this. We got to remove it." And I had a whole panic attack. And my blood pressure shot up, and they did a fine needle aspiration to drain it, to get it small enough so that it wasn't causing the pressure on my spine. But so something like that, if they could say, we can remove that and not paralyze you, I think I may have done. I haven't had a problem with it since. Okay. So once again, hindsight is 20/20. If I had then would I have done it then? Maybe, but now knowing now they did the aspiration and it's fine, maybe not. But there's a lot to consider with it. I guess my overall answer to your question that I've said in a long roundabout way is I would give it more consideration now. I can't give you a definitive answer, but I am not as definitely no as I was then. I'm not at the level of panic attack with the thought of it as I was then.
Okay. So if you're just tuning in, this is Straight Talk with Dr. Lisa, and we are talking with Mr. Dwayne Boyd, a cancer survivor, and Dr. Sarah Horton, a cancer doctor. And I understand we have a couple of questions. So before we go on and talk about prevention a little bit, let's get these questions from the audience.
Be nice.
Be nice. So Yasmin, I hope I'm pronouncing your name properly, Yasmin. Yasmin Blake wants to know, what is the difference between a tumor and a lesion? That's a great one. Dr. Sarah, what's the difference?
Well, I know so listening to Dwayne, his doctor may have said something a little different, but I'll just tell you for me, a lot of the terms are a little bit interchangeable. Meaning you may hear a doctor, when it comes to cancer, use this term to describe a cancerous mass. So they may say mass. There's a mass on the lung. If someone's reading an X-ray, there was a mass. Mass is usually something that is seen, usually on an X-ray. It's not clear what it is yet. And so mass is one of those terms that just is descriptive, meaning it's just describing what's being seen, and the next step is to determine and figure out what it is, right? So there's mass, there's lesion. Lesion is kind of like mass. Lesion is usually seen, either they see it on your body, like a mole or something that looks suspicious. There's a lesion, or on the CAT scan or X-rays, they will see an area that it looks like it should not be there and may be cancerous. Lesion is commonly used in the brain. The term mass is very similar, and it tends to be used in other places of the body, a mass in the lung, a mass on the breast. Lesions are just used in the brain to say, we're seeing something that shouldn't be there. It may, sometimes they can tell by looking at it if it's cancerous or not. A lot of times they can't, and they'll say the next step is to, either biopsy it if they need to.
Yeah, but it sounds like you might be splitting hairs a little bit, Dr. Sarah, because I think it's a really great question Yasmin's asking, because we use these terms interchangeably and people are confused. Like, well, what is it? So I think that's a really great question. Thank you for asking that, Yasmin.
And yet the one last thing I want to bring home to Yasmin is that those terms don't necessarily mean it's cancer. So if you hear that, does not mean it's cancer. It just means it's something that's suspicious.
Yeah. And in my line of work, it could just be an infection that you could either drain, scoop out, or give antibiotics, and poof, it goes away.
Right.
Any more questions? Do we have another question from the audience? We do, from L. Jones. Hi, L. Does dry brushing help prevent cancer? So tell us about dry brushing. Do you know, Dr. Sarah?
I have to say, I don't know. I've heard, I have a younger sister who is into a lot of alternative therapies, and she keeps me on my toes. She did mention dry brushing, which is, and I'm sorry, from what I understand, it's like what it says. You kind of use a brush, some type of brush to kind of, brush yourself, as opposed to, I don't know, washing with the brush. That's when I don't know the details of it. But I will say that from an oncologist standpoint, that may be something that's being looked in the alternative community. But from my knowledge, there hasn't been any scientific studies that are showing that dry brushing, helps to prevent cancer. It may be in the early stages. A lot of the times, if something looks like it might be preventing cancer, they'll do an actual study. There's a whole area at the National Cancer Institute, or the National Institutes of Health, the National Center for Complementary and Alternative Medicine, where they test these things. So I'm sorry, I can't speak to dry brushing.
Yeah, so and I think the idea behind dry brushing, though, is that it is stimulating we were talking about the lymphatic system, so the lymph nodes that drain, and the idea is that when you do that technique, it's activating your lymph nodes to continue draining toxins away and those sorts of things. And so I completely agree with you, Dr. Sarah. There's no data or no research to show us that it makes a difference at all. However, it is very relaxing, and anything you can do to relax yourself, to de-stress, that's always going to be a good thing in prevention.
Right.
Which is a great segue to my next question, which is for you, Dr. Sarah.
Okay.
Is cancer preventable? And if so, how?
So the big answer I give is that not all cancers are preventable, but there are things that we can do as humans to help prevent cancer from happening to us. So some things are within our control, some things are not. Cancer is not caused by one thing. I wish it was that simple, then it would be much easier to have a cure. But we know cancer is made up of a lot of what we call genetic changes. We're all made up of protein and DNAs in our body that we get from our parents when we're born. And those proteins and DNA kind of have the messages to make our eye color and, how tall we're going to be and the sound of our voice. But it also gives us the messages of, this cell in your lifetime may start to grow in a way that may turn into cancer. So things like that, along with things that we may be able to control, things that we know from the environment can cause cancer, like smoking, right? That's an easy one. So not everybody who smokes has cancer, but a lot of people with lung cancer were smokers. So, if It may be that you had a change in your DNA, that you were born with it. May put you at a kind of a risk for lung cancer, but if you never smoked, you'd never get lung cancer, right? You add that with the smoking, which damages DNA and breaks it down, that person develops lung cancer. So we say if you avoid smoking, then at least you're decreasing the chance that if you even had a chance of a cancer, you can help avoid it. So in terms of preventing cancer, not smoking, what we know now is that exercise, even a little bit of exercise, we kind of say if you can get in 2 to 3 times a week, and it doesn't have to be hard sweating, just the fact that you're moving your body helps to prevent cancer, several different types of cancer.
So just walking even.
Walking and just getting up, and if you park your car far from the store, that type of thing will give you some exercise. So separate from that is also what we call your BMI, your body mass index, or your weight. It's kind of your height and your weight. Keeping that at a certain level that's appropriate for your body, your height and your weight, helps to prevent cancer. In terms of UV light, ultraviolet light. Even though you don't find melanoma in a lot of Black people, we get melanoma, get it on your hands and your feet, but using sunscreen when you're outside, avoiding ultraviolet lights, tanning beds. There are a number of different things you can do.
Yeah. So Dwayne, we've had private conversations about the neighborhood we live in and why it might be difficult to be healthy. Can you talk a little bit about some of the challenges to prevention? If cancer is linked to things we can do to prevent the onset, why might it be difficult in your neighborhood to avoid getting cancer?
Well, we've talked about things like nutrition. Nutrition is very important, I think, in cancer prevention. And we talked about the healthy foods you can eat, and a lot of us who live in lower income Black communities being in a food desert. There are not a lot of healthy food choices available, or there are more unhealthy food choices available, such as, I'll pass 5 or 6 carryouts before I get somewhere where there's fresh produce. So you're hungry and you want something to eat now, and you're walking down the street. Are you going to get those chicken wings you smell coming from the carryout, or are you going to go get a bag of lettuce and make a salad?
Yes.
Also, the problem we've talked about my own personal struggles, and I'm around a lot of smokers, a lot of people selling loose cigarettes, and if you can't afford to buy a pack, you can buy 2 or 3 singles. And there's not a lot of smoking cessation information.
Right.
Also, smoking cessation, if you want to do it, like the information I got is you can't do it alone. You need classes, you need medications like nicotine patch or nicotine gum or Chantix, these type of things. If you don't have insurance, these things are expensive. So there's not a lot of effort to prevent things in this neighborhood that the government makes money from, such as alcohol, cheap food, and liquor.
Oh, wow. That's a really good point. So what do you think the solutions are to help people be healthier in underserved neighborhoods?
Education, we've always said that.
What kind of education?
Like on smoking cessation, the benefits
of
health
education.
Okay, so let's just say in the same places, so let's say there was a requirement that in the same, there's the Surgeon General's warning on a pack of cigarettes. Let's say we did more in the areas that sell cigarettes, where you can buy cigarettes. There's also information on how to quit. Pamphlets or a phone number. If you want to quit, here's what you can do. Here's a hotline. Here's a number. Here's a link you can go to. Now you can put a link up with one of the little things that you can scan that people can use on their phone, and takes them the information about quitting. Maybe we can make the same. They definitely make the effort to get their tax money. I mean, somebody died in the street in New York for selling a loose cigarette. Why can't we put that much effort into putting up information as how people can quit? They raise the taxes on soft drinks to discourage people because it's an unhealthy choice. So what you do is raise the tax. Well, that just gets you more money, because people are going to still continue to drink the soda.
Is it working? The soda tax?
I I don't know. I don't know. I know raising the price of cigarettes doesn't seem to deter people from smoking. More people smoke. Just find cheaper ways to buy cigarettes, so you switch to a cheaper brand. But it seems to me that if you're addicted to something like that, you're going to continue to do what it is you need to do to get your drug, be it nicotine, sugar, whatever it is. You're going to pay the price or find another way to get it. That doesn't seem to be a preventive measure for me, raising the price or raising the tax. That just gives the government more money. So it would be nice. How about you take some of that money that you're making and put it into more preventive measures or more educational matters? Why this is unhealthy for you? What you can do to stop doing this? Not stop making the options so prevalent. Stores like CVS and places like that have stopped selling cigarettes. To me, that's a step in the right direction.
When are you going to launch your campaign?
Which campaign are we talking about?
You throw up for office. All those great ideas.
I need to be somebody behind the scenes because I have way too many skeletons to run for public skeletons. Yeah, skeletons you could pull up and watch. So
okay.
Office is out of the question. But I have a question for Dr. Sarah before we move on. So
because we have other questions from the audience. So go ahead and ask your question for Dr. Sarah, and then we'll get the questions from the audience. So go ahead.
So Dr. Sarah, when we were talking about the cutting and the cancer spreading, and you moved into the type of cancer. So did we get a definitive? Where did we fall definitive in that? Like for me, if in my situation, you asked me about would I have the surgery now? If I had that surgery, if I have the surgery now and have these lymph nodes removed, am I at risk of my cancer spreading because I allowed them to cut me?
Right. So I'll answer no, and I'll tell you why. Because when there's cancer, there are very, very specific types of surgery that are done to prevent that. And they're called oncologic surgery.
Cancer surgeries.
Right. So oncology is just another way of saying cancer. So you have to have a special surgeon, a surgical oncologist to do the surgery. So you don't have a general surgeon going in to do your cancer surgery. You have someone who knows that you need to cut wide enough around where the cancer is to prevent from cutting through it. You try to avoid cutting through it. You know that there are lymph nodes. We know, as we've talked about, that the first place the cancer cell goes from where it starts is usually to a lymph node. And so whenever there's a cancer surgery, the surgeon knows to go and take all those lymph nodes that are around the area where the cancer is, so that those could be looked at. And that gives you an idea if any of the cells were already able to go to the lymph node. That gives you information about how likely it is to possibly come back in the future. If it's already gone to the lymph nodes, that may mean we need to add a little extra treatment, maybe some chemotherapy on there, as opposed to if there was nothing in the lymph nodes, then we would feel more confident that everything was gotten with the surgery. So just to say that, the surgery, we do so many cancer surgeries. And if surgery causes cancer to spread and die, nobody would ever survive.
Right. So. Okay. Thank you.
But I also think it's worth re-emphasizing the reason so many people believe this myth that once you open someone and it catches air, it spreads, is because they're being diagnosed late. And we can prevent that. So let's take these questions. There are some questions from the audience, but then let's pick up on that about why people are being diagnosed late. So we have a question from Thomas. Is that Thomas Good or Good? I'm not sure. He says, Dr. Sarah, with exclamation points. I guess it's someone you know. How can we educate and encourage African Americans about the importance to participate in clinical trials? That's a good one.
A man after my heart. Yeah. So clinical trials, in which that's one thing since the pandemic and coronavirus, there's been a lot of education about clinical trials and in terms of what they are and hopefully, taking time to address some of the myths, especially in the African American community. So for me, clinical trials are really important. because it's something that I did when I was at Howard. I also worked at the FDA, where we just reviewed the clinical trials that are being done to see that they're being done in the right way and that the results are correct. So a clinical trial, when you hear that term, and sometimes people use the word a study, those are ways that we find out if a treatment works or not. And so if a company or a pharmaceutical company, in the lab, they develop something, a new drug, it looks like in the lab, it's looking like it's really going to be good, because that's where you start when you're trying to determine whether a treatment's going to work. Usually you start with a petri dish with some cells in it. We have like breast cancer cells and lung cancer cells, and they put the drug in there, and then if it looks like it works, then they'll go to mice. They'll go to mice, and unfortunately, the way that we test on mice is we give the mice cancer, and then we give that treatment to the mouse, and we see if it causes the tumor to shrink. Excuse me. And those are called preclinical or animal studies. And then if that looks good, then we go to testing it in humans. And there are 3 phases. Excuse me.
Oh, you guys okay? What's going on?
Like contagious. He walked on me. I'm under. Walked on me.
So there are three phases of studies or clinical trials in humans. There's phase 1, phase 2, and phase 3. And we've been hearing a lot about phase 3, which are the last phases with the coronavirus studies. And that's when the phase 1 is when you tested a little bit of it. Not a little bit, in a few people. Usually it's anywhere from 10 to 50 people. And you'll test the drug, and you're just seeing if it's safe, period. You're testing it, and you're finding a dose that is safe for the patient. And then this phase 2 is when you take the dose that you found and you know it's safe, and you start looking to see if it really affects that tumor, right? So then that phase 2 is seeing how well it works at causing whatever cancer, it is, to go away or shrink down. And if it looks like it's as good as what we already have as the standard of care, meaning what everybody uses as the best right now, if it looks like it could be as good, then you set up a phase 3 study where you compare the two. And that's the traditional way we take a drug through the different clinical trial studies. So all that to say is the only way we get new good drugs is to have a clinical trial to prove that it's as good as what we've got. And there are all kinds of safety measures that are taken before you get to comparing it to what we've got to make sure that it's safe and that it really looks like it's going to work. It's not like they pull some random drug and say, oh, I think we're going to test this against, and so you may get a drug that is awful and doesn't do anything. No, we already have enough information from the first 2 phases to say, this is looking like this is going to be a pretty good drug. So that's why I think it's important for us as a people, as Black people, but us in general as people, to be involved in clinical trials if you have some type of disease that there may be a clinical trial for. There are some areas of cancer even where we've gotten pretty good at treating it, so there's not really clinical trials. There's nothing kind of new, or it may be one that we just don't have good drugs for and we're still looking. But so I always tell my patients and my family members, and I just say, if it's something that, being a doctor, you kind of know areas that there's good research being done, I'll say, ask your doctor about clinical trials, because if you're on a clinical trial, and I know Dr. Lisa is going to talk a little bit about her coronavirus experience.
I wasn't planning to. It's a great, you're on a roll. Keep going.
Okay, I'm almost done. But if you're on a clinical trial, then not only are you getting something, you're getting the standard of care, the gold standard, or something that may be better. So in general, it very rarely is it worse than what is the gold standard. Hopefully it'll be better. But you're also, these studies, they keep such a close eye on you. When we were seeing, you get follow-up, you get really good care, you potentially get the cutting edge medicine that's the next best thing, and you get people watching you so closely, and you become part of history because everything that your experience is being documented and will be used to decide if this is our next
Sure.
standard of care.
Thank you for explaining that, Dr. Sarah, and just a reminder to people who heard that very elegant explanation about research trials. The vaccines we have for COVID-19 went through that exact process Dr. Sarah just explained. And so that's why, yes, I agreed to be in the trial because I knew it went through that process and the vaccines were safe. So thank you so much for that, Dr. Sarah.
Oh, sure.
But to answer your question, Thomas, you also wanted to know how to get more people, Black people, enrolled in the trials. I think making sure they understand what Sarah just explained. So this is not a situation in which we're taking advantage of people. And we need Black people to be in these trials to help us understand if the medications work.
Give them money.
What?
Give them
What'd
money.
you say?
Give them some money.
Sometimes they do that.
Sometimes they do, but not all the time.
Right.
Yeah. All right. We have another question from Odetta Buell. I'm sorry if I'm mispronouncing your name, Odetta. She says, can radiation treatment cause lymphedema?
That's a good question.
And what is lymphedema, Dr. Sarah?
So lymphedema is a swelling that can that can happen in your body part. Usually it's in when I say extremity, an arm or a leg, because your lymph nodes that we talked about that are all over your body, you've got them under your arms, you've got them in your groin, you got them in your neck. Part of what they do is they drain fluid. Anytime something happens to you, especially if something happens that is damages that part of the body, your body's reaction is to fix it, and fluid is part of what happens. And when everything's done and that fluid needs to be drained away, your lymphatic system does it, and it drains fluid all the time. But if something happens where something damages the lymph nodes, either they're removed or they're damaged so they don't work well, then fluid doesn't get removed from that part of the body like it should, and you can get swelling. And you may have seen people who may have like one arm that's really swollen or a leg that's really swollen, and it may be because they had something that affected the lymph nodes in that area so that they don't work very well. So that's lymphedema. And with cancer, because we commonly remove the lymph nodes around the area of a cancer if they've had surgery, or if there's cancer in the lymph nodes, they may have radiation to those areas also. Those are two ways that the lymph system can be disrupted or changed so it doesn't work very well. So radiation is used for breast cancer, for example. If someone had a breast cancer and they had the breast cancer removed, and part of that surgery, that's cancer surgery, is to remove the lymph nodes under the arms. Usually we've gotten it now to a point where we take the minimum that we need. And we did clinical trial after clinical trial to see how can we remove the fewest lymph nodes, but still get really good results in terms of getting the cancer. And so there's a whole procedure where we only remove like anywhere from 1 to 3, where it used to be 25 lymph nodes were removed. And if you go back to the 50s or the 60s, when women were having these surgeries where everybody got these lymph nodes removed, there was a lot of lymphedema, women walking around with these arms because larger arms, one larger than the other. So the short answer to the question is, it can, but radiation usually doesn't. We fine tune not only surgery, but radiation in a way that usually when it's given, it does not, and it's given in a way to decrease the chance of lymphedema happening. And I think the last numbers that I saw were about 5 to 10% of women. So if you got 100 women and they all had radiation or surgery for breast cancer, then 5 to 10 of them may have the swelling of the arm.
And while we're on the subject of lymph nodes, so as Dr. Sarah's already explained, they are throughout our body. From here all the way down, we have lymph nodes, and they have a function. But the body can send signals to tell you something's not right. And we are very good, myself included, sometimes ignoring the signals. And so one of the signals you get from these lymph nodes is that they swell up. And so I've even seen people who may have had a small node, and then it just continued to grow and grow and grow. And what did they do? They ignored it because they thought, well, it'll go away, or it doesn't hurt, or it's not that bad. So I want to remind everybody, when your body is sending you signals like that, just go and get it checked out.
Because cancer was diagnosed. I'm sorry, I didn't mean to interrupt you.
Say it again.
That is actually how my cancer got diagnosed, because I had lymph nodes that were swollen and painful, and actually the ones I had were in my groin. So, of course.
And how long did you wait to be seen?
Because I've had other health conditions, and I know that swollen lymph nodes are a sign that something's wrong. It didn't take me long at all, because I had that information. But for those who don't, the lymph nodes, once they swell, that is definitely a sign something's wrong. When your lymph nodes are swollen, anytime your lymph nodes swell up, as my doctor explained to me, that means they're overactive. That means they're fighting an infection.
Right.
If they're swollen and painful, it means they're working harder than they should be. They're under a strain, which means your body's under attack. Yeah. So, if your lymph nodes are swollen past 3 days, and especially if they're painful to touch, if they're tender to touch, go get that seen right away.
Yeah.
So it only took me 3 days.
It took you how long?
It took me 3 days.
Good.
After 3 days of having swollen, painful lymph nodes, I said, okay, something's wrong, especially in my groin, because, it hurt. It was like something's going on in my groin. I get that checked out. So.
All right, we have one more question, or at least right now we do, and I want to invite, if you're listening and watching the show, this is Straight Talk with Dr. Lisa. We are talking about cancer. Please leave your questions for us so that we can answer your questions. So we have a question from Christine Clara Conrad Williams. Is it true that having a higher D3 level can prevent cancer? So what is D3, Dr. Sarah?
Well, that's vitamin D. And so that's a great question, because vitamin D is everywhere now. It's like, just take vitamin D and everything will be all right. But vitamin D, so there are definitely some good properties to vitamin D. And it doesn't have a direct prevention of cancer, but it has been associated with, in some studies, when they looked at the things that were contributing towards the group of people who had less cancer, those who were not deficient in D3 tended to have less cancer. So kind of what we go with now is we just want to make sure people aren't deficient in D3. And I say that because some people have interpreted that I need to just take a lot of vitamin D, just take a lot of vitamin D. And to that, some doctors prescribe a lot. Like you hear 20,000 units of vitamin D, but mainly that's being prescribed when someone doesn't have enough vitamin D already. So I always say, before you start taking these doses, go to your doctor, make sure you know what your level is, because too much vitamin D can be bad for you too. Too much any vitamin that you're taking over there.
Yeah.
Do you take vitamin D, Dwayne?
I do.
Yeah.
As much as I can.
Yeah, I do too.
What does that mean? As much as you can?
I don't, like she said, too much can be harmful, so I don't take too many doses. I think I take 100 I use a day. I'd have to look and see. But
how many of the pills do you take a day?
One.
Just one.
Oh, okay. So that's not as much as you can. I was getting a little worried.
I could take the whole bottle at one time, Dr. Lisa. Of course, I'm not doing that, but I take it every day, is what I meant to say.
Okay. Well, I can get behind that.
Yeah, and I do. I mean, the recommended daily D3 is about, like you said, I think it was 80 IU, or
I take 100.
And so, right. So vitamin D is good at preventing osteoporosis as well. So, I mean, I've always taken it for my bones. Honestly, with the coronavirus, there have been different takes, and I'd like to know Dr. Lisa's take on vitamin D. I take a little bit of vitamin D. Added one in the afternoon when corona came in. So,
well, it certainly won't help with preventing coronavirus infection, right? Or if you get it, it could also, because it's an immune booster. It does help your immune system. The trouble is people are saying it's a treatment for COVID-19, and that is not true. So if you've been taking vitamin D, it can protect you from getting COVID-19. But once you've got COVID-19, vitamin D is not going to save you. So it's very different. So take it before you get sick to stay healthy. Yeah. So this is such a great conversation. And there are other things we need to talk about, but I know we're coming close to the end of our time together. And I just want to quickly cover a couple things with you, Dr. Sarah and Dwayne. One is screening. If cancer can be prevented, it's with screening. So what's our take-home message, and what should people do to prevent cancer with respect to screening? Why are you laughing, Dwayne?
I was talking to a friend who is having his first ever prostate exam soon, and he's past the point where he should have had it, and he's a little nervous about it. And it's like, how do I delicately say this? I guess it's a concern among heterosexual men having a prostate exam, and I'm just like, you need to get past that, because colon cancer is a lot worse than the exam.
Right.
The exam is uncomfortable for a couple of seconds. The cancer is uncomfortable for a much longer point of time if it doesn't kill you. So get over that finger fear and go get your prostate checked. That's why I just recently had that conversation. So that's why that was fun.
Well, thank you. That's really valuable information.
Yes.
And that's straight talk, Dwayne.
It is straight talk for straight men.
So, Dr. Sarah, screenings. So in about a minute, tell people what they can do to prevent cancer. Why are screenings important?
All right. So I'm going to try to quickly go through the type of screening that's available now for certain cancers. There's not a screen for all cancers, but as we know, if you are a smoker or you have been a smoker in the past, there is a screening. It's called a low dose lung CAT scan. Have you had one, Dwayne?
I'm sorry, I was distracted.
I was distracted making jokes.
There we were. I was rude while you were talking. Can you repeat the question, please?
It's okay. I just wondered, because you were talking about being around smokers. I don't know if you were or are a smoker, but if so, have you ever had a lung?
I plead the fifth.
Okay.
Yes,
Okay. Have you ever had a screening, a lung screening CT scan for lung cancer?
I know I have been checked for lung cancer. I don't remember specifically that was the name of the scan because I've had so many, but I know I have been screened for lung cancer.
Okay. And if you've had CT scan for your cancer,
I've had a CT scan and a PET scan. So.
But we have 1 minute left, and I think the take-home message is, if you get screened early enough, you can prevent cancer. And this is why it's so important to have a primary care provider, because this is a person who can help you get all those screenings you need. Right. And if you're seeing them regularly, you'll catch this early enough and you won't have a bad outcome from cancer most of the time.
And we know, we talked about Chadwick Boseman, these young people with colon cancers and colonoscopies. And if you are 45 and you're Black, you should have had your first colonoscopy.
Yes. All right.
And your first prostate exam. Get those prostate exams done. I mean,
so we have to go. We have to go. This has been so great. Please share the video. We have resources for you in the chat. And this has been a great show. Thank you so much, Dwayne Boyd, Dr. Sarah Horton, and this is Dr. Lisa signing off. Straight Talk with Dr. Lisa. We'll see you next week.
Everybody.